A very warm welcome to everybody to today's webinar, which is Cognitive Screening Tools, what to use, when, what the results mean, and how to take a really useful history. I'm delighted today we've got Dr. Ben Harris presenting for us, a fantastic webinar, and I'm your facilitator, Nicola Graham. And I just want to say a really warm welcome to everybody. I can see a lot of people just getting online now. We've got a huge amount of attendees today, so obviously a really important and relevant topic for everybody. And we've got people across Australia and even a few overseas people attending today, so a really, really warm welcome to you all. We like to start all of our programs with an acknowledgement to country. So in the spirit of reconciliation, MS Limited acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So it's my great pleasure to introduce to you today Dr. Ben Harris. Now, Ben, as you can see his qualifications and his memberships on the screen, he's a clinical neuropsychologist. He's worked for both St. Vincent's Health and Monash Health in a variety of senior clinical roles. Ben's particular interests include rehab, stroke, traumatic brain injury, adult and aged psychiatry, differential diagnosis of dementia and movement disorders. Ben's now working solely in private practice. He runs independent medical examinations for the legal community across a range of issues, including brain injury type and severity, assessment of decision-making capacity, and cognitive impairment in the context of medical negligence matters. So over the years, Ben's had a keen interest in MS. He did a student placement way back in 2003, working with people who have MS. And his work in that area is directed towards developing an understanding of an individual's relative cognitive strengths and weaknesses, and then using this information to implement meaningful strategies and interventions. And I know that's very much what our audience is very keen to hear about today. So on that note, I'm going to hand over to you, Ben. So Ben and I are just going to change screens.
Okay, thank you very much, Nicola. Can you hear me okay?
We can hear you beautifully and we can see your slide. That's great. All good.
Excellent. Okay, well, yeah, thank you very much for having me and for everyone for tuning in. And thanks for the warm welcome. And as Nicola mentioned, today we're going to be talking about cognitive screening tools, and also I wanted to spend a fair bit of time talking about how to take a useful clinical history, because I don't think that's something that's taught very often, and it's extremely helpful in most clinical situations. So I won't be spending much time talking specifically about MS, just because I think the issue of cognitive screening and history taking and how to sort of look at cognitive examinations is much more broad than that. It's applies to sort of many different settings. So I think I'd take a more general approach, but this can certainly be applied to people with MS. So just what we'll do today is talk a bit about understanding cognitive screening measures. I'll look a fair bit about the MMSE. That is the most studied cognitive screening measure around. It's been around for a long time, and it's used in many settings. I'll talk a bit about additional sort of newer cognitive screens, and then probably spend the second half looking at how to take a clinical history. All right, so just in terms of cognitive screening broadly, the reason obviously why they're done is that detailed cognitive examination, either by someone like a geriatrician or psychiatrist or neuropsychologist, it's often not available, that type of testing, particularly in say an inpatient setting. And such sort of testing is also time consuming and quite expensive for an individual or an organisation. So I think this is where cognitive screening sort of is so heavily relied upon. A lot of times it sort of just forms a basis for any sort of examination, and that's sort of okay in my opinion, but it should be acknowledged that screening cognition is not just a risk-free sort of benign procedure that can be done to somebody. there are risks about, what if you do find something, and is the person sort of prepared for being told there is a cognitive impairment problem for them, or have they got dementia? And this can certainly obviously set up a lot of anxiety. As I'll talk about soon, a lot of the tests, particularly the screening measures, they're not often hugely sensitive, and they can be quite non-specific as well. So there's risks of things like false positives, so that being diagnosing someone, say, with cognitive impairment or dementia when they don't have it. And that obviously carries stigma and anxiety and all sorts of things. So just to make the point that just sort of screening cognitive impairment or ability just willy-nilly is sort of has its problems, basically. And should note that although cognitive screens are used in a variety of contexts, they basically have all been, by and large, developed for detecting dementia. So even though they might be being used in people with MS or in people with traumatic brain injury, for example, that's not the context in which they were developed. And then just a study sort of from about 10 or so years ago, they sampled a whole bunch of geriatric specialists and obviously found that the MMSC is the most commonly used test out there. And then this was followed by things like clock drawing, word recall, which is probably just can you remember these 3 words, and then again in a few minutes time, verbal fluency. Probably since that time, other sorts of tests like the MOCA have become a bit more common as well. So, but this was back sort of quite some time ago when that was done. So just talking about the mini mental state examination. So this was created a long time ago. Now it's sort of coming up to nearly 50 years ago. And it was created by a Dr. Marshall Folstein. And he, as I'll say in the next slide, basically sort of knowing that sort of detailed cognitive examinations were too cumbersome in sort of inpatient settings, which is where he primarily worked, sort of tried to distill some of the aspects of those cognitive assessments into something that was quick and able to be sort of given to someone with, in a few minutes to try and elicit whether they've got any cognitive problems. There's sort of 2 broad sections, if you like. There's verbal responses for things like orientation, memory, attention. And then there's things like reading and writing, which covers things like the written commands, the copying, the writing a sentence, those sorts of things. So this was primarily invented to look at elderly patients. And it was interesting in a quote from him, he sort of basically said that there were loads of possible items that I could have selected. I basically picked those which I could remember and that I could do at the bedside without any equipment. So, that's maybe not the best rationale for creating a measure of cognitive functioning. It was sort of done on an ad hoc basis, I think. And as this quote down the bottom says, that the MMSC, when it was created, was probably for a particular clinical setting, and the makers of the instrument had no idea at the time that it would become so popular and used basically whenever and wherever, despite reservations that might be had with the test. So it's important to keep that in mind. It's certainly not a foolproof instrument. So just looking at the caveats or sort of issues with the MMSE, and these do also apply to every other measure of cognitive assessment, so any other cognitive screen, and also neuropsychological instruments all are affected by things like the age of the person that you're assessing, and also how much education the person's had. So background factors. The thing about neuropsych tests is that we interpret them in the setting of normative data. So you basically take an individual person, and when you give them a particular test of their cognition, you compare it to a big sample of data that that sort of takes into account a person's age and often their education as well. So, but that's often not the case with measures like the MMSE or the MOCA. So just with the effect of age on the MMSE. This is quite an old study now, but it serves a useful purpose, which has been validated since then. But they looked at a large sample of people in the community without cognitive impairment, and basically measured them from the age of 18 up to over the age of 85, and they showed basically a significant inverse relationship between age and the score. So basically, the older you get, the worse you tend to do on the MMSE. So you can see that in younger groups, the median score of the MMSE is almost 30 out of 30, whereas you get to the age of 80 plus and you're looking at a score of 25 out of 30. So often people use things like a 24 out of 30 cutoff for MMSE being the sort of point at which someone calls it dementia or not dementia. And you can see why that could be problematic if the person's, in their 80s, for example, because half the population's sort of by and large is going to perform below that sort of mark. So that's just a graphical representation of the sort of declining scores in MMSE as a function of age. You also need to consider the impact of education as well. So this first point is from the same study. It looked at also the effect of education. So independent of age, if a person's, so this is across the whole 18 to 85 plus sample, if a person's had sort of very little education, 0 to 4 years, the median MMSE score is only 22 out of 30. So very low, below the so-called dementia sort of cutoff that's typically used. 5 to 8 years of education, you're sort of in the mid-20s, and then basically if you've had 9+ years of education, regardless of your age, you should be sort of nearly scoring perfect marks on the MMSE. So it's important to sort of have this context that age of the person, education of the person really plays a bearing on how you would expect them to perform on any of these instruments. And this is why I'll spend some time talking about how to take a history, because you sort of need to know the person you're dealing with in order to have some expectations as to how they should perform. So I think this bottom point is really interesting in that certainly there is a massive interaction between age and education. So you look at the first point, if you're over 85 and you've had less than 4 years of education, the median MMSE score is only 20. But if you're over 85 and you've been college educated, then again, you're in the high 20s. So knowing about a person's background is critical. Okay, are there any questions at this point, Nicola?
No questions yet, Ben, but again, do encourage people to type their questions in just so we give you a bit of a break as well, Ben.
Indeed. Okay, so now I just wanted to talk quickly about some statistical issues. Sorry to do this, but I think it's quite important in terms of explaining about cognitive screens and just cognitive testing generally. There are two sort of ideas that are worth understanding. So, and there's two sides of the same coin, if you like. So they're called sensitivity and specificity of a test. And so basically, how to explain this, the sensitivity of a test is the ability of the test you're giving to identify in a sample of people those that have the condition you're looking for. So say if you're testing for dementia, for example, and you're using a particular cognitive test, the sensitivity of that test is out of, I suppose, 100 people that I give that test to and who fail that test, how many of those have dementia, basically? So the proportion that I've been able to pick up with that test. And then the specificity is the other side of that coin. So it's the ability of your test to correctly identify the people who don't have the condition. So out of all the people I gave my test to who passed the test, what percentage of those people didn't have dementia? So they sort of sound a bit like the same thing, but they're important, as I'll explain in a minute. So basically this is a sort of graphical representation, if you like, of the population. The pluses are people with dementia who are, based on some other measure, like the gold standard, if you like, are absolutely known to have dementia. And by the same token, these are the percentage of the population that are absolutely known to be normal or not have dementia. And so it's basically 50-50 in the population, in this population. So when you look at the sensitivity of your test, so this would be like what the results ended up being like. So it's saying that if you have a test that's 60% sensitive, it means out of the 10 people in your population that had dementia, your test, if it's 60% sensitive, is only picking up 6 of those 10 people. So it means that of the out of the 6 people that failed the test, there were another 4 people that didn't fail the test but did actually have dementia. So that's what sensitivity means, how sensitive the test is to picking up the condition. And then specificity is, so the same test, say this is a specificity of 80%, it means of the 80% of people that passed your test, there were still 2 out of 10 that failed the test that didn't have dementia. So they would be what's called a false positive. So they've failed your test. So you might say they've got dementia, but they don't in fact have dementia. So 20% of the sample is testing positive, but not actually having the condition. And 40% of the people with the condition weren't testing positive to it. So this is what the issues of sensitivity and specificity mean. I don't know if I've explained that well, but I'll proceed. But then you get into sort of issues of how good is your test, basically, based on the sensitivity and specificity. So again, an older study looked at if you were using a cutoff of 23 out of 30 with the MMSC, they found that when looking for people in hospital to try to detect delirium and dementia, if you use 23 out of 30, they were picking up 80% of the people that did have that problem, dementia or delirium, and of the people that tested positive, of the people that didn't test positive, there were only 18% that did have dementia or delirium that were picked up. So it's indicating that it's a reasonably good test at that level, but there's still sort of 15 to 20% of people that are either being false positive or false negative based on that cutoff. And whether something, and the sensitivity and specificity of any particular test will change depending on the population. So for example, if you're using a very old population or a very poorly educated or highly educated population, then these sort of markers will differ based on the population.
Ben, I've got a couple of questions, if you don't mind me interrupting, but they're
no, not at all. Yeah.
Good questions. So we've got one from Sam saying, who'd be a qualified practitioner or clinician to actually conduct the MMSE?
That's a good question. I think I know in a practical situation in hospitals, it can be sort of given by most different people. It's often given by allied health staff, so OTs, speech pathologists, nurses, and also and doctors as well. So it's probably more a case. There's nothing with any of these cognitive tests and neuropsychological tests as well. There's nothing particularly tricky about giving the test as such. You know, there are rules to follow and there are ways to score the test. It's not rocket science giving the tests, but it's more about how the tests are used and how they're interpreted would be the thing for me. So I think someone who's using these tests needs to have been firstly well trained in how to do them accurately and reliably, but then it's what do you do with that information afterwards, which is particularly important.
And another question from Sam here, thanks Ben. Is this assessment appropriate to be used for people with mental health or mild intellectual disability who've been recommended to have a cognitive capacity assessment, obviously considering their age and education as influencing factors?
Yeah, I'll sort of talk to that a little bit in down the track, but yeah, there are issues with that. So sort of bearing in mind that so things like age and education impact how someone is likely to score on these screening measures or any cognitive measure. So do things like you know, history of mental illness, things like schizophrenia or severe depression, or like you say, sort of intellectual disabilities. They all are known to impact significantly on how someone will score on these tests. So yeah, that's again where specialist interpretation of the tests and why I'm going to spend a fair bit of time talking about history taking, because all of that is pretty central to how these things are interpreted.
Thanks, Ben. And just lastly, a quick question here. As people
Yep.
and clients evolve or change over time, how long is the result of this assessment valid for? When would you consider redoing the assessment?
I would do that on probably clinical grounds. Basic over testing people with things like the MMSC that begins to lack sort of, particularly if the person hasn't got like a major memory impairment. They get practice with the test. They sort of know exactly what's coming up and what the answers are, and so people can get practice effects. Also, in conditions where, say, someone might be cognitively deteriorating, for example, a dementia like an Alzheimer's disease can they wouldn't change generally too rapidly. So it's probably depends on individual circumstances. We don't recommend, for example, in people who are suspected to have Alzheimer's, we wouldn't necessarily recommend a review neuropsych assessment within 12 months of the initial one, because often you're just measuring sort of error in that time, sort of noise due to sort of somebody doing things differently on one day to the next, not necessarily a genuine decline in their cognition, for example.
Great, thanks, Ben. And sorry, just one last one. If someone fails the test but has dementia, then is another test used?
Yeah, so well, again, that probably depends on the setting that you're seeing the person in. And I mean, the thing for me is I don't use these tests myself. I tend to do the neuropsychology test, the sort of more in-depth sort of assessment of cognition. So yeah, so it depends on the setting whether you would follow up. Usually, the idea of these tests is they're screening measures, so that they, someone might come to you and say, "Oh, I've got a memory problem," or "My husband's got a memory problem," and then you might administer one of these tests. And then if they have problems with it, that can be a red flag to say, well, that person needs to go on to have specialist examination of what this problem is. That's the way in which they're intended to be used. But it's whether or not that follow-up investigation is available. But yeah, these are meant to be screens. They're not diagnostic instruments as such.
Okay, great. Thanks, Ben. That's we'll move on from there. There's still other questions coming in, but we'll move on and we'll address some of the other ones offline. Thank you.
Sure. Okay. All right. So all the research that's been done on the MMSE, it certainly has its uses, but there are some significant shortfalls that people need to know about. So it's generally pretty good at determining if you take a person without any cognitive impairment and a person with pretty significant dementia, you can generally tell those two people apart. But it doesn't really help you when you're trying to determine someone with normal cognition versus someone with mild cognitive problems. So whether that be the early stages of a dementia or mild cognitive change in a condition like MS or a traumatic brain injury, for example. It's good at those broad ends, but not so much the more subtle delineation. And the MMSE, I know it happens a lot, and people say, oh, they scored this on this part of the test and they missed a point on this and that. That's not the way it's meant to be used. It's a very crude sort of screening test, and it should not be used to try and identify specific disorders. It can't really pick up focal lesions, particularly those in the right hemisphere. It doesn't pick up frontal sort of systems impairments due to head injury or stroke, for example. And as I was mentioning before, there's problems to do with false positives because of low education. There's also the problems with false negatives, whereby people who have quite demonstrable cognitive impairment on history, for example, can score very highly on the MMSE. And you don't want to ignore that person and say, well, yeah, you're telling me that you know, or someone's telling me that you can't remember this and you can no longer do that because you can't remember, and blah, blah, blah. And yet you scored 28 out of 30 on the MMSC, so you must be fine. That's a massive clinical error, that one. And this is, again, why the history taking is so important. And as Sam mentioned before, and we just touched on, people with diagnoses not just of dementia, but things like delirium, intellectual disability, significant mental health history as groups, but not necessarily as individuals, all obtain low MMSA scores and low scores on things like the MOCA and the RUDAS and things. So you've really got to know the person to know whether the score you're getting is of any relevance, really. I just put this in because it's a bit of an example. This is someone I saw quite a few years ago. I've seen many of these sorts of cases. So just to go through it, it was a lady I saw in my age psychiatry work. She lived alone. She had done for 16 years after being widowed. She's been and this is sort of where it comes in. She's highly educated. So she completed high school, did a teaching diploma. Relatively speaking, she's reasonably young. She's only in her mid-60s. High functioning person, worked as a teacher, later ran accounts and finances for the family business. But she was referred to me, 2-year history of something seeming off with her cognition and personality changes, I'll explain in a sec. And she came to the attention of our service because her house was found to be extremely squalid and cluttered, and she'd had an industrial clean and it went back to being cluttered and squalid and things. So something was not right. When the team went out to see her, there was major signs of a functional problem. There was rotting food in the fridge that she seemed unaware of and unconcerned about. She was herself not showering, not changing clothes. There were maggots and rodents in the house. She'd lost a heap of weight. Sorry, she gained a heap of weight and was no longer eating a normal diet. She was just eating biscuits and ice cream and things. Family said she'd lost her understanding and interest in other people. She was become quite crude in terms of her social interactions. And so medically, they looked at her with an MRI. So she had atrophy in so shrinkage in the frontal parts of the brain. She was given a SPECT scan, which measures blood flow in various areas of the brain. It was showing that the frontal and temporal and parietal lobes weren't taking up as much blood as they normally would. I saw her and found that on cognitive testing with a proper neuropsychology battery, she had sort of major impairments with complex executive functions, anything that required reasoning and problem solving. She couldn't pay attention. She was very slow, but she wasn't displaying a severe memory impairment, didn't have any problems with her language or her visual perceptual functions. So this lady clearly had dementia. She had major cognitive impairment, major functional change, significant issues in her daily life that were caused by her cognitive impairment. And she had a diagnosis of frontotemporal dementia in the end, but her MMSE was 29 out of 30. So this just serves to highlight that this isn't a particularly unusual situation. This is pretty common, but it just goes to show that these cognitive screening measures, they're certainly not bulletproof, and it's really important to take that other information so that you don't just go, oh yeah, 29 out of 30, she must just be a bit of a strange woman that likes to live in squalor and things. You need to sort of be able to pick up on these things, and it's about questioning the results of the cognitive assessment and the importance of the background information. Okay. So just looking quickly, I'm sorry if tuning into the assessment you were looking for me talking for long periods of time about various cognitive assessment tools. I just wanted to provide mainly a framework that they are useful, but they do have all of them have caveats, and that how you interpret them is really the primary thing, and how you interpret them, in my opinion, is the clinical history that you get from a person and their family. But a more recent cognitive assessment that's become quite popular is the Montreal cognitive assessment, the MOCA. This was designed in sort of the early 2000s because of that issue with the MMSC, where it doesn't distinguish milder cognitive impairment from normal cognition. So and also the idea that the mini mental, it doesn't really pick up on things like executive problems and problems with sort of speed of thinking or mental flexibility, those sorts of more complex things, the more so-called frontal processes. So they've tried to sort of build that in a bit more. So the mocker then has, again, it assesses short-term memory with a few more items than the MMSC. It's got 5 instead of 3 words. There's a bit more complex visuospatial stuff. So instead of the pentagons, it uses a cube and gets a person to draw a clock. It tries to put in some executive type measures like trail making B, which is this ability to sort of alternate from 1A, 2B, 3C, that sort of thing. And also similarities, trying to abstract to provide similarities between things like a train and a bicycle and a watch and a ruler and so on. And also a bit more of a complex language test, so naming these animals, whereas the naming tests on the MMSC, name a watch and a pencil, is extremely insensitive to any language impairment. So on the face of it, it certainly is probably an improved test, and it's been found to sort of perform better than the MMSC, particularly with respect to the detection of MCI being mild cognitive impairment. So that's a situation where somebody's got on history signs of something not being right with their cognition compared to how it used to be. And that if you tested them with neuropsychological batteries, then you would find that there is a deficit there, but the deficit's not so severe that it's impacting on their daily life. So it's there, but it's not having a functional impact just yet. So this initial study with the mocker from 2005 found that if you used a cutoff of someone scoring below 26 from 30, that the mocker was picking up 90% of people with MCI, so mild cognitive impairment, whereas the mini mental state exam would only pick up 18% of those people. So that's a significant improvement. And that the sensitivity was much higher with the mocker compared to the MMSE as well. And that's for both being sensitive to the diagnosis of Alzheimer's, but also and specific for normal cognition. So basically, if you get over 26, there's an 80% chance that you don't have dementia. You still got a 13% chance of having it, but this is again the issue with these sensitivity and specificity calculations. And when screening for MCI, mild cognitive impairment, again, a newer study from a couple of years ago found that sensitivity was high, specificity is lower, but that's okay in a sense as long as you use additional background information. So specificity being that 18% of people that passed the test still had a problem, but there should be other ways of picking this up, which I'll discuss. And whether something is sensitive or specific to a particular level will depend on the cutoff score you use. So if you use a cutoff score of, say, anything under 30 out of 30 is a problem, then you won't be very sensitive to the condition. It basically depends on where you put that cutoff. So, all right, are there any questions, Nicola?
Yes, there's quite a few. So I'm just filtering a few and picking a few questions out, and we'll handle other ones separately. So Heather's asked, Ben, what age group can the mocker be used for?
Look, I haven't looked into that specifically. It's a good question because it certainly does. It is impacted by age, and I think being a more complicated test and one that uses small parts of neuropsychological instruments that I use that I know is impacted by age, it certainly would be impacted by age. So again, it's about where you set your sort of cutoff, and that would be based on an individual sort of person. But I think, yeah, you could use it at any age really. It's just that you'd need to know that probably testing someone on the mocker who's over the age of 80, probably if they scored under 26, you'd still have to be a bit careful that that's not a normal score, basically.
Okay, and Ben, Jennifer's asking, what cognitive screens would you recommend for Parkinson's disease, as I've found the mocker blind and RUDAS all have time-sensitive components that those with PD do poorly in?
Yeah, I think the thing about that is that you probably that's a good question. What you're best to do is to give somebody a good cognitive screening measure. So the mocker is, say, a good test, for example, but you just need to then interpret why a person's performed poorly. So and to be honest, like slowed speed of processing in Parkinson's disease is a cognitive issue. Motor component of slowing maybe is not so much, but I think what they suggested with any of these cognitive screens, sort of best practice, is to administer the screening measure and score, even if, say, somebody can't write, for example, on the MMSE, so they can't use the dominant hand, for example, and they're meant to write a sentence, you should still score that 0 out of 1 for that item of the assessment, but you should be able to explain then why a person's lost points in various subsections. So I would apply that to the Parkinson's example as well. I think pick the sort of cognitive screens that you're used to using and the ones that you feel most comfortable using, and things like the mocker and the RUDAS are fine, but just be mindful as to why a person might have perform poorly or more poorly, say, based on those particular difficulties that are specific to, say, Parkinson's disease, and just make sure that that's explained when you write the results somewhere.
Thanks, Ben. And also just a quick question here around the appropriateness of these assessments for clients from cold communities, from non-English speaking.
Yeah, so that's a big issue. And so, for example, like the MMSC, and I think also now that things like the mocker have been translated into other languages. So there are ways to get around the pure English as a second language factor, and by using interpreters and things like that. But there is also an issue of cultural difference as well. And I know that in certain assessments that I give, that people from different cultures just don't seem to, they haven't been, there must be something specific to, say, Western style education that teaches certain things at school, for example, where they maybe don't seem to be taught the same way in other cultures. So they might perform very poorly on a test of something you think it's measuring. But it might just be that the person's just never really known that, it's never been told to them. So cultural impacts are very important and worth trying to understand in your interpretation of results. I was just going to talk about the RUDAS briefly, which has been designed to try and get around some of those cultural language and educational sort of difficulties. So shall I talk about that briefly, Nicola?
I think that would be great. Thanks, Ben.
Yeah, so and again, it's not a perfect test, but it's an attempt to try and it's trying to take the more esoteric aspects of cognitive assessment, like count backwards from 100 by subtracting 7 as a measure of attention, for example. It's trying to sort of take that that's obviously quite educationally loaded and probably culturally loaded, and trying to make the cognitive assessment more something that you, just as a normally developing human being, might have come across in your life. So, for example, the memory component is not just sort of 3 or 5 random words. It's presented to a person like, you're going to the shops. I'm going to give you a list of 4 things that you have to remember. So, it's trying to take the cognitive components of it and put them in a bit of a real life context. So it's trying to measure things like executive function in the form of being able to make a judgment about something So in something like the MOCA, the executive functions measured by the trail making test and the similarities between two words, whereas in this RUDAS test, it's about, you know, so you're standing at the side of a busy road and there's no pedestrian crossing around you. So what would you do to try and get to the other side of the road safely? And so that person's then got to sort of say, well, you know, I'd look both ways. I'd wait till the traffic stopped, and, you know, or come up with some sort of solution to it. But again, it's in a bit more of a naturalistic setting. It's based on something they've probably done before, or they'd be expected to know. So that's where the RUDAS has been developed from. That's that idea to try and put these measures of cognition into a more normal context for a person, so it loads less on things like culture and education. And the initial sort of studies of the RUDAS showed that it was had fairly good specificity and sensitivity for dementia, at a cutoff of 23 out of 30, so still a fairly low cutoff. And a more recent study looked at a review of a whole lot of different articles, sort of 11 different articles that had 1,200 different participants. The sensitivity to dementia was lower, it was only picking up 77% of people with dementia who had dementia. So based on them failing the test, still 23% of people that passed had a problem. And yeah, about 14% of false positives as well. So, but it's found overall that it is an improvement on the MMSC with respect to things like culture, language, and education. All right, so that's probably, I'm about to change topics now. So if anyone wanted to ask any questions now, Nicola.
Ben, there's lots of questions and some of them are quite detailed, so a number of them we'll need to take offline. So I think if we continue on, and I'll ask a few appropriate questions a little bit later on. But it's great to see people so engaged, and obviously a topic that is posing a lot of questions for people. So it's great, guys, and we will address your questions offline if we don't get to them today.
Okay, great. So this is sort of really what I wanted to talk about is this history taking, because for me it doesn't matter if so my own work as a neuropsychologist, and I give lots and lots of tests to people, and you're looking at all the cognitive domains. You're looking at memory, concentration, speed of thinking, problem solving, sort of conceptual reasoning, executive functioning, language, and so on and so on. You're doing loads of different tests of these things, but at the end of the day, all of those results need to sit in a context, because as was mentioned before, whether you've got a background history of a learning disorder or ADHD or MS or a severe psychiatric problem, will affect your cognitive profile. And so how a person's coming out, whether it be on a detailed assessment or on a cognitive screen, may or may not be suggestive of an acquired problem or any other type of developmental problem. So it needs to be put into this context so that it can be understood better. All right, so, and I would also say, like, as well as making your assessment much more robust and clinically useful, spending the time taking a history with an individual and possibly with their family as well, that also helps to build a relationship with them, and that that's a much better clinical contact for the person. They're going to feel a lot better about what's happened, and it also, if you spend the time talking with them before you, for example, give cognitive assessment of them, I find it tends to make them more relaxed as well. And so when you actually do the cognitive testing, you tend to minimize problems that might come up because the person's anxious and like a deer in the headlights, for example, or can't stand the sight of you because you haven't spent 5 minutes talking to them, and they just can't be bothered sort of answering your questions. So it helps to make the assessment that you do more valid and reliable as well. Okay, so just going through what I would tend to do in an interview, and this might take half an hour or so, and longer if it's particularly complex. So it will depend on whether you have the time in a particular setting, but if you do, it's very useful. But you're looking at multiple aspects of a person's current abilities and their situation in the context of what's previously been the case for them. And obviously corroboration is important wherever possible. So getting a collateral history from someone who knows them well, because people with cognitive problems, particularly say MS is a good example, may not have superb awareness of those issues. So it's great to get a second opinion about that. And just at an observational level, if you're asking a person a lot of questions about background history and things, particularly in with another person present who might be providing the collateral history, noticing the person's ability to contribute to the interview themselves is particularly important, or are they relying on the other person to sort of fill in details, specific sort of examples that you might be asking them about? That can give an insight into whether there's a problem going on cognitively. Okay, so often, so particularly important is what we call pre-morbid function. So how the person functioned before there was any problem with their cognition. So you sort of need to take this right back to the beginning. So usually look at the person's upbringing, sort of how stable was the household. You know, was the person coming from a sort of stable, happy environment, or was it a particularly tumultuous, neglectful, abusive environment? That certainly has impacts on things like education. So how easily was the person able to access education? And when they were there signs of things like attentional disorders, learning difficulties? Did they need to repeat any grades, or did they need special assistance? Because all of these things give a clue to a person's lifelong sort of level of academic sort of capacity. And a lot of the tests we do are influenced by education. So understanding a person's background education is particularly important. You need to look at sort of how far through school they went. As I mentioned at the beginning, number of years of schooling done does significantly impact these tests that we do. And often it's asking people about, so someone might have, you just sort of say, oh, so how many years of school do you do? And they said, oh, I did 8 years of school. Trying to understand that, particularly in the older population, I find that you sort of ask them maybe why they stopped going to school, or what they did then, and you'll often find that it was because our family couldn't afford us to go to school anymore, but I was actually a really good student, and the teachers were really disappointed I couldn't go on, or there are often other reasons to explain why someone might have only done a lesser amount of education that may not have a bearing on their background intellectual ability, for example. So you need to sort of also ask them about the work that they've done throughout their life. Get an idea as to what was involved in that job. So if someone sort of says, oh, look, I've worked in a factory for 30 years, it's quite different if they were working at a very low level in the factory, or if they sort of started off at that level, and after 5 years they were running the place and responsible for organising all of the staff and training up new staff, and so those sorts of things give you an idea as to a person's likely level of previous ability. And also understanding what their usual routine and input into various things like household and community activities were like within the family. So certainly so we'll often see sort of elderly people, for example, who say it's an elderly man, for example, and he and so you sort of ask what they sort of do during the day, and it might be, well, I don't do any housework, I don't do any cooking, I don't do any cleaning, and you think, oh, maybe this person's not traveling too well cognitively. But then if you speak to their wife, for example, that might be culturally completely appropriate. And so it's about sort of understanding what would be usual and expected of that particular person. And it's important to find out what their usual personality was. A lot of quite a few of the cognitive conditions that come up often, so disorders of frontal system, say through head injury or certain types of dementia and even MS to a point, that can affect social style and interaction. So the interest a person might have in other people and their sort of willingness to socialize, you need to sort of work out what a person's always been like. So have they always been a sort of reclusive person, or did they used to be the life of the party and then something's changed? So it's sort of like basically looking at what's always been the case for a person in many different areas and finding out and then trying to find any contrast that might be coming up now. I think we're sort of running shortish on time, so I won't. These are the other things that you need to be looking at as well, sort of psychiatric history, as this has a bearing on how a person's cognition might have been affected, neurological and medical events that might affect cognition, medications that people are taking, and previous substance abuse. These are all important factors that can contribute to cognitive problems. And in terms of like detecting a cognitive issue at the current point in time, you really want to know basically when and how this all came about. So you want to get a sense of, when did you first become concerned about so-and-so's cognition, and in hindsight, were there signs that this happened before to suggest it's been a gradual onset, or has it been the result of an acute sort of stress or that might suggest maybe a psychological component to it, or was it in relation to a particular medical illness? And also whether once the cognitive problems have come on, what they've done since then. So have they stayed the same, or have they improved, or have they got worse over time? Because all of those things are really important information to understand. Various injuries and diseases have I suppose natural sort of rates of change over time, and so whether someone's continuing to decline or staying stable, for example, can be quite an important distinguishing feature between, say, if someone's I'm seeing this all the time, so someone has had a head injury, for example, and it might have unmasked an Alzheimer's condition that's going on before. So the natural course of a head injury would be that you have a declining cognition, an improvement, and then a period of stability. Whereas someone where it's unmasked a dementia, they'll have a declining cognition, maybe an improvement, and then a progression of symptoms. So that time frame and what's been going on is particularly important. And these are things that don't necessarily require specific expertise to ask about. It's just being aware as to why you might be asking, and knowing about certain conditions, and to get a sense of how they might sort of show themselves on interview. And there are certain types of cognitive functioning you can pick up by taking a careful history. So if you're looking at somebody's ability to for short-term memory, so you sort of want to ask, and this is one where you often need an informant, because people with short-term memory impairment, they often don't remember what they've forgotten, if you like. So they're not really aware of all the times they've forgotten because of their memory impairment. So asking someone close to them, do they remember recent conversations, and particularly ones that they were paying attention to. So maybe more important conversations, so things about something major that's happened in life. Did they forget something that seemed really significant? Are they repetitive in conversation? Do they sort of ask you the same questions even though you've already answered that question? Do they need prompting and things to get on top of things, such as upcoming appointments? Whether a person's got longer term memory impairment is often pretty clear from a clinical history. So if you ask them, for example, to, say a person's got 3 or 4 brothers and sisters, and then you ask them to tell you their names, and then the names of the people's husbands and wives, and maybe their children and things, you can get a sense as to whether that's an easy thing for them to do, or whether it, there's huge blanks where there shouldn't be. Things like, when they were married, sort of where that happened, and can they remember those sorts of major life events. If people are struggling to remember those, that's usually a pretty good sign that there's a cognitive problem and a memory impairment. Yeah, and things like you can look for evidence of slow thinking and language problems in conversation with a person. And obviously, a lot of times people that are developing cognitive problems for whatever reason, some of them more complex thinking functions like decision making and planning are quite noticeably affected. So you might ask about, things like, have there been any examples in the last sort of little while where someone's become confused by something that happened a bit out of the blue, or did they get upset by a change in routine, or have they made any bad decisions recently that seemed a bit rash? So they're the sorts of questions you can be answering to elicit this sort of information. And as I was saying before about the usual personality, so finding out what they were used to be like, there are plenty of people around who are naturally socially withdrawn, don't like other people, a bit irritable, and so on. So if that's the way they've always been and that's the way they are now, then fair enough. But sometimes you'll see in the context of cognitive impairment, often what happens is a person was a bit like that, but now they're a lot like that. And so understanding whether something's happened that's really made that a lot worse is important. Or has there been completely sort of different sort of change in their sort of behavior completely? So have they been a very kind of calm and warm and sociable person who's now irritable and aggressive and doesn't care about other people? And is that a complete change in personality? Because that would usually suggest that there's something organic going on potentially. So, all right, we're getting there. Okay. And in terms of functioning, so I've sort of taken this this conversation in the context of looking at dementia, for example. So where the issue of whether someone's cognitive problems are affecting their functioning is quite important to diagnosis. So often when people have a cognitive problem, and say take MS for example, there's usually some concurrent physical issue going on as well. So so someone with MS might have problems with spasticity or weakness or balance, for example. And so if you're asking somebody as to, why they can no longer, do their shopping at the supermarket and someone's had to do that for them, you really need to kind of go into some detail about that. Is the reason they're not going to the supermarket anymore because it was physically too difficult and they had a fall when they were there one time and so they've lost confidence? Or is it because they were going and they were getting in a muddle and they were coming back and they hadn't bought the things they needed to do to buy? And so it was coming more from a cognitive standpoint, or is it some combination of the both? So asking specifically about why somebody may not be able to do a particular thing anymore, and understanding whether it's due to some sort of physical problem or is it due to more of a mood problem to do with, say, depression, for example, or is it a cognitive problem? Those things are really important in terms of background diagnosis. And in order to know whether something's a change for an individual, you need to know what they used to do. So that's where getting the background history is so important. And sort of, I also sort of, if you're looking at a person's sort of cognitive functioning, it's often a good gauge as to, it's not always reliable, but whether their partner or someone close to them is actually concerned about this. So you will get some partners that are, not wanting to know about it and they're either oblivious to it or, don't want there to be a problem. So, and on the other side of the coin, you might get some partners that are a bit too intense about the whole thing and they're nitpicking and they're picking up on the most minute things that maybe don't represent a problem. But probably for the most situations that I find, a reasonable gauge is whether other people are concerned, because they're the ones that know the person for a longer period of time. They know what intrinsically the person used to be like, and so if they're coming to you now saying, hey, something was wrong with mum or my husband or whatever, then that's usually a bit a pretty good red flag that you you should be listening to them about it. And then you need to ask all of these questions if you can. And these are some of the other things that we look at as well in terms of more complex activities of daily living. So cognitive, and it's usually the more complex things that will start to be impacted by earlier cognitive impairment. So it'll be the more difficult to do things like driving or managing medications, or managing finances, for example, that require a little bit more regular sort of checking in and decision making and things to sort of get to the bottom of. But they're the sort of things that might fray around the edges to begin with in terms of milder cognitive change. Often we ask things like, so your husband's still driving, but would you trust him to drive the grandkids to school, for example? And because oftentimes there will be things like, oh yeah, he still drives to the shops, but there's absolutely no way I would let him do that. And then you ask why, and it's like, oh, because he, scraped the car the other day and he got lost sort of 3 weeks ago. And then you think, oh, hang on a sec, there is sort of something going on here. So asking sort of those types of questions is important. And I think because we're getting towards the end, I'll just skip over this, but it's the same sort of thing really. And you need to basically sort of ask at this level about the domestic task, community activities and things. And so this is the final slide. So in terms of history taking, there's lots of things that you can just observe about the person. So things like, do they have problems with word finding and speech during your conversation with them? Do they seem slowed up or lack facial expression and normal reactivity in their emotional engagement? Those things can be signs of other problems in engagement terms. And I would say, like, a lot of the stuff and a big document that addresses all of these different things that we've spoken about: the past history, the current history, how long it's been, what's happened, and so on. And I would say that type of information is invaluable. It makes the work of the specialist so much easier. It really does help enormously. So even if you're practicing in a situation where you're not the one making a diagnosis as such, gathering this information is hugely helpful to other people that are going to be sort of engaged maybe at more of that high-level cognitive testing or making diagnoses and things, because the history of the condition, I think, is just as important as any cognitive assessment results, and you can't really have one without the other. They complement each other really well. So, okay, that's pretty much what I wanted to say. So I'll hand back over to Nicola now.
Ben, thank you so much. I think you've really given us an idea around the context and the nuance and the considerations that people really need to take into consideration when they're doing a cognitive assessment. And thank you for sharing your wisdom over the years of how to take a really good cognitive history. The slides are fantastic, and they're really going to help our attendees to really get a good cog history off their clients. So thank you, Ben. I'm just going to take the screen back and just very briefly do some quick housekeeping slides to finish off for today. So thanks, guys. So you should be able to see my screen now, and just wanting to remind you of some of the services that we provide here at MSL. So we look after NDIS clients, we do support coordination, we have allied health practitioners here, we have residential care, education, we have a really important free MS helpline service with specialist advice and information that you can call for health professional support, but also that your clients can call for any assistance that they might need. And we have employment support as well. And lots of resources for you. We have a wonderful podcast series aimed for your clients, but lots of really good, useful information for health professionals as well. We have, for example, an online ebook library that you can access. And we have our Inform newsletter with upcoming CPD webinars, etc. If you have any questions, please don't hesitate to email us. You can call the gateway to all of our services, which is via MS Connect, which is the 1800 042 138. Just want to say a really big thank you to you, Ben, and thank you to everybody listening. And we will follow up independently the questions that we weren't able to cover today. So thanks, guys. Great to have seen you all and shared the webinar with you today. And big thanks to you, Ben. Bye for now.
You're welcome. Thanks.